Hi, I'm Paul. I'm a medical oncologist, and I admit I am powerless to make a diagnosis of lung cancer. I do have several disclosures. The biggest disclosure I want to make is I am convinced there are now 4 pillars in the management and treatment of lung cancer. The traditional thoracic surgical oncologist, thoracic radiation oncologist, thoracic medical oncologist, but now thoracic pulmonary oncologist. That all 4 pillars are needed to treat lung cancer. Because it has to be a team, and every member of the team needs to know where you want to end up, to know where you're going and how to get there, because we each have different steps of how to get where you're going and where you want to end up. And I'm going to focus from the thoracic medical oncologist perspective on 2 things: that treatment matters and time matters. And this is just the explosion in lung cancer that's far exceeded any other solid tumor on actionable mutations, and now we're down to 2nd and 3rd line targeted tyrosine kinase inhibitors. And immune therapy, immune checkpoint blockade, is still less than 2 years young as an explosion. And believe me, as a thoracic medical oncologist, and we've treated over 100 individuals with anti-PD-1 therapy, we are seeing things that we never ever could see before. The 2 most important slides are right here. This is just looking at targeted therapy, no targeted therapy. If there is an actionable mutation and you get the targeted therapy, compared to if there's an actionable mutation and you don't target that, the median survival drops by 18 months, and the 4 to 5 year survival drops by 10 to 15%. If you do not evaluate for an actionable mutation, you might as well tell the patient, you could live 18 months longer, but I'm not going to bother. Oh, you could have a 10 to 15% chance of being alive higher at the 4 to 5 year mark, but it really doesn't bother. I'm really not going to bother. Tissue is always a problem, and it's easy from the podium, everybody gets the tissue. But the second slide is, tissue being the gold standard is an alternative fact. It was the gold standard because that's all we knew and we thought it was gold. And this is just looking at the EGFR T790M mutation and just focusing on tissue and plasma. 13% of the time it was in plasma, not in tissue. Likewise, 13% of the time it was in tissue, not in plasma. So both are needed to fully assess, is there an actionable mutation that is a dramatic extension of life in an advanced lung cancer. And tissue is still the standard for PD-L1, but yes, we get the next generation sequencing in our program. If PD-L1 by the Merck assay is greater than 50%, they're getting upfront immune checkpoint blockade and more upfront chemo with immune checkpoint blockade. But this is focusing on the targeted therapies. Now, who should we evaluate? Current smokers still can be EGFR positive, poorly differentiated, TGF1 negative, 30% of ALK smokers, and even squamous. That looks like squamous. EGFR could be positive, ALK can be positive. 1%, well, for that person, that's a huge difference. And this was a study that blew my mind away. This was from ASCO at World Lung in 2015, ASCO last year, from Southern California and the Bonnie Adario Foundation, of looking at stage 4 lung cancer patients under the age of 40. 83% had an actionable mutation, but it was not dominantly EGFR. 46% were ALK. 46% with ALK. And ALK is ERCC1 high, which means a lot of DNA repair, so the platinum adducts are going to be repaired, so platinum is not that effective. So under the age of 40, if you don't know ALK, you're given potentially ineffective therapy. And 2 other things about ALK. ALK is the #1 lung cancer incidence of brain metastases. It's 60% will evolve to get brain mets if you have an ALK mutation. That is higher than small cell. Now we have alectinib, second/third generation, that 43% of the time, there can be a complete radiographic response of the brain mets with a simple targeted kinase inhibitor. You don't need whole brain radiation therapy. You need the right therapy. And it used to be, we talked about a 70% response rate, median progression-free survival 10 to 13 months. Now the next generations are getting 90+% response rate, and alectinib, median progression-free survival not reached at 29 months. That's really carrying the day forward. And it's not just stage 4 disease. Looking at the bottom in the middle, E, stage 1, if you have a KRAS G12C, stage 1 lung cancer, surgically resected, 2 out of 3 patients are dead by the 5 years. Stage 1, 2 out of 3 are dead at 5 years. For CyberKnife, stereotactic blade radiation, KRAS, by 2 years, everybody's recurred. KRAS is bad. We need to know even for stage 3. Yeah, local control is great with an EGFR mutated stage 3 with CRT, but distant metastatic disease invariably develops. KRAS is particularly bad, no matter what stage. And KRAS, we cannot target it yet, but KRAS can give powerful treatment signals. This is just looking at an in vitro assay of response, and G12C platinum resistant, but will respond to pemetrexed and a taxane. G12V, strongly sensitive. G12D is paclitaxel resistant and maybe the one subset that does respond to sorafenib. But we have to think beyond that. This is just a recent study. Interleukin-6 blockade reprograms lung tumor microenvironment to limit the development of progression of KRAS mutant lung cancer. Oh, so cetuximab, tocilizumab, we have anti-IL-6 therapies. The monitoring with liquid biopsies is going to be huge, probably evolving to what CML is. You get your BCR-ABL by PCR, you don't need anything but that. If you clear your mutation, you are going to do better, which means if you don't clear it, you need to do something else. And I can envision the day where we don't need to get surveillance scans. Even the decision on adjuvant chemotherapy may rest with what we can get from circulating free DNA mutational analysis. The Veristrat-4, as Mark mentioned, is bad, and that's just a proteomic inflammatory assay. But this is upfront chemotherapy. Upfront chemotherapy in a non-squamous, progression-free survival 1.6 months, overall survival 3.4 months with chemotherapy. In the BR21 study that compared placebo versus erlotinib, second and third line, when Veristrat-4 was evaluated, if you got placebo, progression-free survival was 1.7 months, overall survival median was 3 months. So chemotherapy in the setting of Veristrat-4 is arguably not any better than placebo. So something has to be done different. Now, a progression-free survival of 1.6 months, you're going to re-image every couple cycles. That's going to be 3 weeks, so that's 1.5 months. So nobody's really responding to the Veristrat-4. So you just have to do something different, and you need this up front so that your thinking is different. This is one of the most phenomenal studies that I've thought about. At the time, I thought it was just soft and fuzzy, but this was presented at ASCO last year from the French group. And it is looking at web-based identification. These are patients that have a lung cancer treated, and if they develop any recurrent symptoms, they have a web app that they can immediately contact their oncologist's office, immediately get in. This was compared to the standard. How often are you going to monitor somebody? Every 2 to 3 months, get your CT. I will see you. Call if you have problems, but we'll do something so that we really don't get you in and because you have an upcoming. So the earliest onset of symptoms compared to the standard surveillance. Now, severity of symptoms aside, but the progression-free survival with chemotherapy, whether immediately started upon any symptomatic development or the standard, progression-free survival was the same. But what we see is not what we get. The overall survival in the patients that had immediate institution of chemotherapy did much better. Even though their disease did not look any better, the biology of the disease was impacted. So time matters in treatment across all stages, in my opinion, even stage 4. This is just looking at 2 quick cases. This was an individual that Mark Bronk got started on chemo right away. Cisplatin doublet, standard of care, no response after 1 cycle. KRAS G12C, switched to PIM and paclitaxel. Pain better, functional pulmonary status markedly better. And this is an individual that goes back to Halloween Friday in 2014 that Mark Bronk at 6, 7 o'clock at night. Everybody stayed after dark when Halloween treats are going on. But 42-year-old, never smoker, found in her own vomit by her husband, mother, 2 elementary daughters, extensive brain mets, lung, nodal disease, mass, and had a left bony met. Mark Bronchter, who got the diagnosis, she had to have whole brain. We gave her systemic chemotherapy with whole brain. We needed a rapid response or she was going to die. She ended up having an EGFR exon 19 by tissue. In May of 2016, she recurred, and she had both an exon 19 deletion and an exon 20 T790M. Now we do have osimertinib, which is effective in the T790M. And we know with EGFR mutated lung cancers, immune checkpoint inhibitors are not effective. In fact, the hazard ratio is 1.18 and 1.22. And she had a rib met, 2 sacral mets, and 2 iliac crest mets. That was May. Here she is, December 28th, her PET completely negative. What we did was cyberknife 2 of the iliac crest. We actually gave her anti-PD-1, kept the erlotinib ongoing so that the T790M clone would still be there, because there are snippets of information that the T790M EGFR mutation is immunogenic, is immune responsive. Now yes, she is on osimertinib, and right now is back being a full-time mom, a full-time wife, and is a very active kickboxer. 1,500 years ago, everybody knew that the Earth was the center of the universe. 500 years ago, everybody knew the Earth was flat. 15 minutes ago, Agent K to Agent J, you knew people were alone on this Earth. But imagine what we will know tomorrow. And that's where things are with lung cancer. Imagine what we will know tomorrow. It's the most exciting and impactful time ever in the management of lung cancer, and it's because it's everybody together knowing where we want to end up and doing everything we can to end up there. Thank you.